Oh, very good evening to all of you. A very late evening. First of all, thank you to the West Bengal Academy of Echo for this kind invitation. So let's get down to the presentation. It's a very common problem which has been there for a long time. Lots and lots of literature around it. Atrial fibrillation. Sorry about that. So let's look at the recent guidelines which came out from the European Society of Cardiology. So this is a nice figure which shows the AF right in the center, and then you have these two orbiters. The inner orbiter are the background of the patients, where you have the aging, ethnicity, the male sex, and genetics, and then you have the outer orbiters, the outer circle. You have these various diseases. So this is what sort of really reflects what atrial fibrillation is all about, with multiple problems and backgrounds. The causes for atrial fibrillation you can table it in many ways. So this is one such table. It can be divided into cardiac causes, non-cardiac causes, and then you have these highlighted areas. So this is where the structural changes takes place. So in terms of looking at the effect of coronary artery disease, the myocardium, and then you have the congenital, and then you have the valvular disease. So these are the areas where echo can be very helpful. On the non-cardiac side, you have a very limited approach in terms of what echo can provide. So primarily it is looking at the infiltrative disease or the pulmonary embolism. Now, the mechanism of AF itself can be sort of summarized in a very sort of it's too simplistic here, but I guess the message gets across. So you have the AF here, and then you have these three areas: the atrial tachycardia remodeling, and then you have the genetic variants, and then you have the RAS activation. So these three have an impact on the electrical and the structural also. While you have the extracardiac causes, and then you have the infiltrative a part of it, and then the autonomic nervous system is directly impacting the atrial, while the other one is on the structural abnormalities. Now let's look at some prediction models which have been tried. So some of the oldest, these were the pioneers, so to speak, the trendsetters from which the data started and then where it has grown. So you have the Framingham Heart Study, the ERIC study, and then the Women's Health Study. So they looked at the patient background. Hypertension was a key parameter, and then the ECG was there, clinical examination, and then the risk factor. So based on this, algorithms were developed, and over a period of time they have changed, and then you have a lot of predictive models right now. Now, looking at imaging in atrial fibrillation. So this is taken from the 2020 ESC guidelines. So the primary approach is to look at the anatomy, look at the structure, look at the function, and then any abnormalities. And these color bands tell you what each one of them can bring to the table. So you can see that the echo in terms of T can take care of in terms of trying to identify problems, and then the other findings to a large extent, while the MRI is the one which sort of really scores all across. The approach is primarily to look at the LV size, the geometry, and then the valves and its function, and then the right heart, and in terms of pressure. So now focusing on echo itself. What does echo provide in terms of how one can look at predict if there is going to be atrial fibrillation or a patient? So it's primarily to look at cardiac function in terms of the volumes and other parameters, which I'll come to later. Structural changes, looking at the etiology of AF, and also to risk stratify patients. And it is very helpful in terms of management and in decision making. So when it comes to transthoracic echo, it is use of 2D, use of Doppler, and the approach is to look at dimensions, to look at pressures, and then to look at ventricular functions, and then any valvular abnormalities. The newer applications in terms of the tissue Doppler speckle 3D contrast have brought in incremental information, and also has improved the accuracy of the parameters measured. While T has been helpful in terms of looking at the left atrium, looking at the appendage, especially interatrial septum, the pulmonary veins, and then aortic atheromas, and also plays a very crucial role in terms of cardioversion. And then again, in the newer approach in terms of transcatheter closure of left atrial appendage. Intracardiac The echo is also has been mentioned. I have very limited experience and knowledge about this. So it is helpful in terms of providing information for the left atrium and the appendage and the interatrial septum, and also the pulmonary veins, and during the ablation. Now, looking at one of the first parameters, the basic parameter is to look at left atrial size. So the aim is to look at the AP diameter. So this is in the Laparosome long axis. Anything more than 40 millimeters, as we all know, is dilated. So the Framingham Health study showed that every 5 millimeter increase the risk of atrial fibrillation by almost 30%. And any atrial left atrial dilatation of more than 50 millimeters in sinus, those who are having sinus rhythm, they are at fourfold risk of AF. But the problem with LA diameter is that it underestimates true LA size, because the LA can expand in multiple directions. So this is how you can look at in terms of LA size. So the top one shows that it is around 40 millimeters, low risk. And as the size starts to increase, you can see that the risk of developing atrial fibrillation starts to go up. And the last the row shows that the patient has already developed left atrial dilatation significantly and AF. So the size of the LA matters, and it is very important that we monitor this very basic and very simple parameter. But in view of its limitations, so the next one that has been looked at is the left atrial volume. So these are taken from the apical views, and the cutoff value, which has been standardized, is 34 ml when it is indexed. And this is an independent predictor of first atrial fibrillation. And if there is reduced left atrial emptying fractions, this increases the risk of atrial fibrillation. And it is definitely better than the LA diameter. Again, a very simple and easy to do parameter can be done and provides a lot of information. So an example of a patient here, you can see that there is a large left atrium which shows a very high volume. So this is a patient at very high risk. This patient, in fact, is an elderly, he's male, and then a very large left atrium indicates that this patient is at risk of developing atrial fibrillation. The 3D has now come to play in a very big way. So it is now a standard sort of an approach to look at left atrial volume. So this also has been validated, so much more accurate than the 2D LA volume measurement. Then there is pulmonary vein flow. So pulmonary vein flow again has a very crucial role, and it provides a lot of information. So this is how a typical normal pulmonary vein looks like. It has got a systolic flow, and then you have a diastolic flow, and then there is an atrial reversal flow. So what happens in atrial fibrillation is that when it is absent in terms of the atrial reversal, so that is not there in atrial fibrillation, there is reduced systolic flow and there is increased diastolic flow because of the decreased LA function here. And then you have prolonged onset of systolic flow, and then there is appearance of early systolic reversal flow. So this is all part of how one sort of looks at the pulmonary vein, the waves, and then what happens during atrial fibrillation. Now, this has got a very important sort of value in terms of cardioversion. So if these values are low post cardioversion, then we can say that the data says that within a year or even 6 months, these patients can come back to atrial fibrillation. So pulmonary vein flow monitoring and assessment has a very crucial role. And also in patients who have undergone ablation, so it can also be a place where one can look at pulmonary vein stenosis also. Next is to look at LV function. So LV function in terms of volumes, and in terms of looking at the LV ejection fraction. Of course, we do the 2D LVEF, which is a routine one. So 3D LVEF is validated and then very accurate when it is compared to the 2D LVEF. And then from this, one can get LV mass. So increased LV mass also is a parameter which says that there is increased risk of AF. LVGLS also has a role to play in terms of an independent predictor of what really happens to the patient, so especially the global longitudinal strain. The other parameter which one needs to look at in these patients who are at risk of atrial fibrillation, look at the diastolic function. So grading of the severity of diastolic dysfunction can help us to tell us whether these patients are likely to go in for atrial fibrillation. Now, let's look at complications. So, complications can be looked at in terms of how, in terms of medical history, looking at the ECG. We can look at a combined sort of approach, and then look at the ECG in terms of the ambulatory ECG monitoring. The T will play a big role, and then these are the blood markers. CT, MRI is also there. So the main aim is to look at what complications are likely to occur in these patients who have developed AF. So the effects of AF is predominantly on the vessels, it's on the muscle, and it's on the pressures. So as far as echo is concerned, so when we look at echo and when we look at the AF, there is a threefold risk of heart failure, fivefold risk of stroke. So we have to look for any embolism likelihood, and there is increased risk of dementia, and then mortality automatically goes up. So the area where one can look at in terms of complications to see whether the patient is going to develop a complication is to look at LA appendage velocity. Again, a very simple parameter, so especially useful in transverse esophageal echo and especially sort of doable in TEs. So this top one shows a normal velocity, so low likelihood. But once it reaches around 40 centimeters, then SEC starts to appear, and then the onset of thrombus is higher. And once they reach around 20 to 15 centimeters, then the SEC is going to be there, and then the risk of thrombus formation is very high, and thromboembolism is there. So these numbers do matter as far as 20 and 40 are concerned. So left atrial appendage velocity plays a big role. Next is to look at the spontaneous echo contrast. So again, grading of SEC, there are various sort of approaches. So a very simple one is just to look at the visual sort of an approach. So you have very mild SEC here and then very significant SEC here. But once the SEC sort of gets into the left atrial appendage, especially this particular type where it is called as pre-thrombotic sludge, where it's an intermediate type, neither a low flow nor an organized thrombus, but it is a precursor for thrombus. So this is another thing which we have to look into. Next is the thrombus itself. So thrombus can come in various sort of ways. So this is a body thrombus, and then you have the appendage thrombus here, and then this is a really large thrombus spread all over it. And we know that once thrombus is there, the risk of embolism is quite high. So the echo predictors of thromboembolism are valve disease, LV systolic dysfunction, LA dilatation, and also one can look at aortic atheromas by T, the complex ones where you have a mobile component. And then the left atrial appendage velocities, as I showed earlier, less than 20 centimeters per second is high risk. Then there's a lot of excitement, a lot of focus on left atrial strain. So here, left atrial strain can provide us information in terms of function. And also there's been publications, literature, where it has been looked at in terms of can it predict AF, thromboembolic risk, prognosis management. So this is a tool which can combine everything, but in terms of clinical sort of utility, still very limited. When you look at these the CHAT scores, which have got a high number of patients, the number of patients of strain are very, very low, and still there are no standardized sort of acceptable values. So, but an exciting field and definitely something worth looking into. So coming to my last few slides. So apart from the echo, so these are the other scores which are looked into in terms of risk stratification. So you have the stroke prediction, you have these various scores, and then you have the bleeding prediction. So these are the scores to look at what happens if there's a high likelihood of bleeding that can occur in atrial fibrillation. Then, so these are the various sort of ways to look at it. So you have one half where we can try to look at who can sort of develop atrial fibrillation, can we predict? And the second half of my presentation was to look at what complications can occur. And echo plays a crucial role. It has an established role. And with the newer techniques which have come, it has improved imaging in terms of providing incremental information, in terms of providing accuracy. So it provides vital information in terms of function, complications, and very helpful in terms of management and also for prognostic value. Thank you for your kind attention.